Good morning. Thank you, Lorda, and thank you very much for inviting me to come here this morning to talk with you at your workshop. I suppose I should introduce myself. My name's up there. My name's Lindsay McElroy. I'm part of the professional development team at the Royal College of Nursing. And a little bit of the background to how I came to be here. We were commissioned at the RCN to put on a series of programmes, and that was really the title of them, and that was back in 2012. And it was following the work that was being done by a team that was sent in to look at the emergency departments and a lot of the issues that were happening in the ED departments in the region at the time. And one of the issues that was flagged up was the thoughts that perhaps, as was referred to earlier, that people were being sent to EDs that maybe would be managed better in their own environments more appropriately, and particularly elderly, frail people who maybe lay on a trolley for a considerable amount of time, and then some unfortunately passed away on trolleys in emergency rooms. And I think everybody agrees that that is not what anybody would want for our relatives, for our patients, and families and carers, of course, find it extremely stressful, including yourselves, the staff, that we're trying to look after their patients as well. So that was really the background of it, and the theory of the recognising and responding to the deteriorating patient really started off in the acute sector, and I'm sure there's many of you out there who have done immediate life support courses. It would be part of the curriculum now for our pre-reg students that are undergoing their nursing degrees. So it grew in acute care, and it grew there for a very good reason, because back in the day, and when I worked in coronary care, which was quite a while back, we would have had a feeling that there was something wrong and that the patient wasn't going to do well. And I don't know if any of you are familiar with this, but some of us would have wheeled a resuscitation trolley outside their door, which mustn't have instilled the patient with very much confidence, just in case something happened to them. And of course, now that we're a wee bit wiser, we realise that the important thing to do is not to sit back and wait for somebody to go off, as we would have said. It's a lot harder to resuscitate somebody than it is to actually pick up why you think there's something wrong. Why are you feeling that the patient's deteriorating? Go and assess them properly, do something about it, and prevent the cardiac arrest or whatever it is happening, because obviously you have a lot better patient outcomes if you do that. So that's really where it comes from. So it's a bit of acute care background that I decided to try and transfer over to the independent sector in some sort of a fashion that would work for you. So the overall aim of the session was really, pardon me, about patient safety. It's about ensuring that patients are treated in the right place and treated appropriately. So enhancing patient safety, ensuring patients are appropriately monitored, cared for and treated. Now, we started the sessions in 2012 for the registered nurses, but in 2017 and 18, having spoken with one of my colleagues, Dolores McCormick, who you probably all know, is very involved with the independent sector, and we had a discussion about whether we should be transferring this over to nursing assistants, as we're now starting to call our healthcare assistants. Would it be appropriate to be putting on sessions for them as well, since they are the people there that are providing a lot of the personal care and a lot of the hands-on care. So we started to do that in 2017 and 18 as well. The learning outcomes for the sessions then are about analysing the need for early recognition of the deteriorating patient, recognising the signs, evaluating the methods of recording and reporting the deterioration, using the appropriate care pathways as per your local policies. And then we did a practical session which was about the delegates themselves demonstrating how to assess their patients or clients who may be deteriorating using the ABCDE approach, which is the lift from the immediate life support course. And it was really about giving staff more confidence in their own judgments so that they were able to make clinical decisions and be less likely to be told, possibly by somebody in an out-of-hours service, that the best thing that you can do is take this patient to an ED department. And obviously I couldn't cure the issues with the out-of-hours service. That's going to be a bit more complicated. But it was about the nurses having a bit more confidence and improving their communication when they were dealing with staff that were maybe trying to override decisions that they were trying to make as well. So you'd be pleased to hear I'm not going to go through the whole session with you, or you would be here for quite some time. But these are generally the areas that we covered. And we started off by looking at critical events and looking at some of the critical events that have happened before, when they happen, how they happen. And the next point, of course, is recognising that responding to the deteriorating patient is complex and challenging for a variety of reasons. We know that it is more likely for an adverse event to happen if a patient is transferred from an ICU to a ward, a general ward, as opposed to transferred to a high dependency unit. We know there is more chance of critical events if patients are transferred at night time. And basically we know that if staffing is inappropriate and the skill mix is inappropriate, then there is more chance of adverse events happening as well. So night times and weekends can be dangerous times. We know as well, if we're going to have surgery and you're going in for an operation, don't do it on a Friday. So make sure you know that, guys. Get your operation scheduled for a Monday. So that tells us that we need appropriately skilled staff and we need the right numbers of staff to prevent these things from happening. So it is complex and it's not straightforward and easy. We talked about tracks and trends and triggers, which we're very well used to in the acute sector. And I actually showed the delegates the news charts that we use, the early warning systems. So essentially when somebody has a critical event, usually there are signs that we can pick up on. The signs are there and sometimes we don't pick up on them. So it's about tracking, looking at trends, seeing how a patient's condition is deteriorating and actually doing something about it. Something I thought I will leave you with is about if you have a patient that is deteriorating, one of the most important vital signs that you need to be looking at is the respiratory rate. So we all know that in acute care. It's up at the top of our news chart. It's the first vital sign that we check. It's the first alarm bell that goes off. If the respiratory rate is increasing, you need to keep an eye on that patient. There is something happening to them. So what's the rest of their vital signs like? Watch them, look after them, something is happening. So if you don't have the appropriate charts to monitor those patients, then maybe you need to think about that. So maybe that's another job for you guys in RQIA and working along with the homes. I don't know. I always say that it wouldn't be for every patient, obviously, because you've got your patients that you're doing your monthly observations on, and that's fine. It's the patients that you're worried about, so that can help you see clearly that something is happening here. They may be deteriorating, and the little box for the respiratory rate at the bottom of your temperature, pulse and blood pressure chart maybe isn't the best way of monitoring that patient. But that's for you to think about and for you to decide. But it's something that I always throw in there. Recording and reporting, very, very important. What usually happens is, and I talked to the delegates on the course about vital signs. I know it's gone very American, but I think it sounds more important than general observations sound. So we talk about the vital signs, about recording and reporting. And what usually happens with a critical event is perhaps the vital signs were not done when they should have been done. So you look at the charts and there's gaps there. Or perhaps they were done and nobody picked up that there was an issue with it. Or perhaps they were done, somebody picked up there was an issue with it and reported it, but whoever they reported it to didn't do anything about it. Or perhaps the vital signs were recorded, it was picked up that there was an issue, it was reported to somebody, they asked for help to come, and either the help came too late or the help didn't come at all. So those are the issues that we're faced with recording and reporting. And of course, if you're teaching these sessions to nursing assistants, then it's very important that you try and get them to think about making sure that if they have concerns about the patient, about what is happening with them, that they report it on and make their concerns known. I also identify the normal ranges of vital signs, and with registered nurses it can be quite interesting to see what they think are the normal ranges for vital signs. And the other thing that we had to bear in mind in these sessions with the independent sector was that when you're dealing with elderly patients, they don't necessarily fall into the textbook range of observations that the rest of the general adult community do. So it's having a little think about that as well. So I suppose that bit's really a bit of revision, as it were. I then talk to them about communication. Usually in any critical events there is a communication part to it somewhere. So in other words, somebody wasn't told, messages weren't passed on, things weren't reported, there was a gap in communication somewhere along the way. And of course, we're all supposed to be great communicators as nurses, but sometimes our communication skills let us down a little bit. So what I go through with the nurses and the nursing assistants is the use of SBAR. And any of you working in acute care in a previous life will know about SBAR and know that if we lift the phone in the trusts and ask to speak to a doctor and say, this is an SBAR call, then they will sit up and take notice. Now, I don't ask the nurses in the independent sector to pick up the phone to the GP and say this is an SBAR call, because they mightn't really know what they're talking about. But I tell them to go through SBAR, keep themselves systematic, put their message through in a systematic and confident way, and people then will sit up and take notice. So basically they talk about, first of all, what is the situation? Then relate anything relevant in the background. And that's not a full medical history. That's if, for example, if the patient had collapsed, maybe they're diabetic. So it's whatever in the background that is relevant, not their whole medical history. Then go through the systematic assessment using your A, B, C, D and E, which I'll talk about in a second. And then the most important bit that we tend not to do is our recommendation. So what's your recommendation? And you tell them what you want them to do. Because sometimes what we have a habit of doing is we give over a history of what's happening and we expect the person that we're talking to then say, oh right, okay, I need to come out and see your patient now, I'll be out shortly. Because you have to bear in mind they have a queue of patients sitting outside their door. I've also noted in the independent sector that your patients have to become unwell before 11 a.m. or there is a bit of difficulty at times. So it's about making the recommendation that you need them to come out and see them and you need them to do it now, because it could be something simple that's going to help that person, a course of antibiotics, a catheter, whatever, that can help them to remain in their own comfortable environment instead of lifting them and sending them into a world of chaos where they can't get the personal attention perhaps that they may need. So that's SBAR. Then I would talk about teamwork, and that's very, very brief. And we know all the research about good teams means good care, good leadership means good standards, etc., etc. A little bit about role modelling, about setting standards, and when you set standards as a registrant and you role model behaviours, that everybody else falls in place with those standards and those behaviours. So that's just very briefly what the session covers. I talked to you about the systematic assessment, and the ABC is our usual ABC that we always used. And any of you, as I say, used to working in acute care will know your D, E and E. So I talk them through how to do an assessment of somebody's airway. Start with the airway, move on to breathing, and of course the first thing you're doing in breathing is checking that respiratory rate, which of course is the vital sign that we're the worst at doing. Start with the respiratory rate, move on to your circulation, then move on to disability. Although it's D for disability, it's actually an assessment of their neurological condition. It's about their level of consciousness. Because essentially, if you have a problem with your airway, your breathing, your circulation, or your level of consciousness, then essentially it can be a fatal problem. So we need to check those 4 things. D is level of consciousness, and E is exposure. And that's sort of the final thing that can put something into place for you. A head-to-toe check. Make sure you're not missing something, and that sometimes is what clicks it in your head. Ah, right, they're covered in a rash, they've collapsed. Maybe we're dealing with anaphylaxis here. So that's our A, B, C, D and E. It's systematic, and we cover that whenever we're handing over our patient to anybody, whether it's the paramedics, whether it's GPs, whether it's other staff, whoever you're communicating with. It is a very good way to hand over a patient. Use your S-bar, use your assessment using your A, B, C, D, E. Think your way through it. Keeps you right, keeps you systematic, and make sure that you don't forget anything, hopefully. Then we go on to the fun bit that everybody enjoys. They get a bit anxious about this. But what we do is we break people up into groups of about 10. We use our mannequins and we give our participants a scenario. Now it could be any one of these scenarios, it just depends what they think, what we think at the time or what we should do. But we use one of these scenarios, give them a patient, and we ask them to go through their assessment, starting with airway, make them be systematic, because as nurses we always want to jump in and check a pulse and do a blood pressure immediately. So we get them to be systematic, think their way through it, do their assessment, and then ask them to hand the patient over using S-bar. And we also say, before you finish your assessment, make sure you've got all the notes and everything beside you, because again, a bit like exposure, putting things into place, you want to know what's just happened with the patient. Has the physio just been walking them up and down for the first time? Is that why they're breathless? What's been happening, and what medications have they received or not received, as the case may be, recently? So that gives you a fuller picture. So that's basically what we do. They are very well evaluated. We have 100% positive evaluation that these sessions are relevant to the daily challenges that they face. So hopefully we have them at the right level for people, to find them informative. And I think it's good as well to be kept up with a lot of the ways of working in the acute sector as well, because your patients are becoming more and more acute as time goes by, and it means that you're not out of the loop also. So that's really what the sessions are all about.